Yes.
A few things.
Um, Good evening, everyone. It's my pleasure to invite you to this very interesting webinar by ICOG, Academics and Perspectives. ICOG, being the academic wing of FOXY, aims at promoting training, research, knowledge dissemination, and strives to advance standards of education and quality of healthcare throughout our country, in especially in the field of obstetrics and gynecology. So, in this context, we have the following program with three very interesting talks encompassing some societies of from Tamil Nadu, Madurai Society, Tirunelveli, Thuthukudi, Nagarkoil, Theni, Pondicherry, and Tiruvannamalai. We'll be having three talks by our esteemed faculty. Our Parag Biniwale sir, ICOG chairman-elect, will be talking about what we have to know about ICOG. This will benefit all of us who are already our fellows FIC have already got FICOG, to get to know what all benefits we can have from ICOG, and also those who are yet to apply. And we have a very interesting talk, Delivery Consideration in GDM by Pratik Tambe sir. And another interesting talk, External Cephalic Version by Lata Chaturvedula ma'am. So looking forward to a very interesting 1 hour. Before we start, we seek blessings from our president of FOXY, Dr. Jaideep Tank, our chairman of ICOG, Dr. Parul Kondawala sir, our Secretary General of FOXY, Madhuri Patil ma'am, and Vice Chairperson of ICOG, Sheila Mane ma'am, and Secretary of ICOG, Sarita Baleru ma'am. And this program is brought to us by Dr. Parag Biniwale sir, who's the Chairperson-elect of ICOG, and it is convened by Dr. Chamila Ayavu ma'am, who's the Vice President of FOXY now. So, Gauri, can I have sir's introduction, please? CV slide. Yes.
Madhu, that's okay. That's okay.
Yes.
Let's begin.
Yes. So,
Yeah.
yes. So it's my honor to introduce Parag sir, who's the chairperson-elect of ICOG and also the past president of Pune Obstetric and Gynecological Society. And sir needs actually no introduction. He has numerous accolades and to his credit. So with this, sir will give an introduction about this webinar and what it means. And after that, we'll move on to the prayer song.
Sure.
Yes.
Thank you, Dr. Madhuvita. Good evening. I bring greetings from ICOG, and it's a pleasure to connect with the Tamil Nadu and Puducherry societies. I must appreciate the efforts put in by Dr. Charmila Ayavu, our governing council member, who's the convener for today's program, and Dr. Madhuvita, who's the coordinator for this program. So thank you all the president, secretaries, and members of the Madurai, Tirunelveli, Thuthukudi, Nagarkoil, Theni, Tiruvannamalai societies of Tamil Nadu, and of course the Puducherry OBGY Society. The concept behind this program is to reach out to members of various societies. Basically, we all of us know that ICOG is the academic wing of FOXY, and whatever knowledge impartment that is done through the ICOG, where we are doing a lot of activities. I'll talk about them in a while. But then this is a reach out to smaller places where our members of FOXY can be part of the academic wing, that is ICOG, and contribute to the knowledge enhancement of our members. At the outset, let me thank the president of FOXY, Dr. Jaideep Tank, especially Dr. Parul Kotadawala, the current chairperson, who allowed me to start this reach out program. Dr. Sheila Mane, the vice chair, Dr. Sarita Bhallerao, the secretary of ICOG, Dr. Madhuri Patel, the secretary general, and all the governing council members who are participating enthusiastically in this program. I must acknowledge presence of Dr. Rustam Sonawala, an iconic figure for all of us, who's past president of FOXY. Thank you very much, sir, for being there and blessing our programs. And I must inform everybody that Dr. Sonawala is one who does attend a lot of programs conducted by ICOG, and he gives some valuable inputs on these programs. Special mention of our very enthusiastic governing council member, Dr. Pratik Tambe, who has also been a convener for the Academics and Perspectives webinar in other states. So, Madhu, let's begin with the prayers and then let's move on to the program.
Yes.
Thank you.
Gauri, can I have the prayer song, please?
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Yes. Can we, Gauri, can we move on to the chairpersons of the first session slide? So, chairpersons for the first session are Dr. Sundar Narayanan, who's a president of Nagarkoil Obstetric and Gynecological Society, and Dr. Shanta Vibala, who's the president of Teni Society. I think I request Sundar Narayanan sir, so please introduce Dr. Parag, sir. So you're muted, sir. Sundar Narayanan sir, you're muted, sir.
Sorry. Yeah,
Yes.
it's a great pleasure to introduce my esteemed colleague as well as a close friend of mine, Dr. Parag Benawale. He's a senior consultant of OBG at Pune and a PG teacher and unit head of Kamala Nehru Hospital. He's also the chairperson elect of ICOG 2024, and he is the president of Pune OBG Society for the years 2022 to 23. He's also a vice chairperson ICOG from 2021 to 23. And he's the president of Menopause Society Pune 2018 to 22 and secretary ICOG from 2018 to 20. And he's the national website editor for Foxy from 2011 to 17 and the peer reviewer for Journal of OBG from 2011 to 17.
Sundar, thank you. That's okay. That's okay. Let's not...
quite I know. Because your credentials are too much, sir. And it is indeed a great pleasure to invite you for the talk. And he is going to talk all about ICOG and how to join ICOG and how to go about it and everything about it. Up to you, sir.
Yeah, thank you. Thank you, Sundar. Yes, I'll... Okay. Good evening yet again. And in next 15 minutes, I'm just going to give some outline about the ICOG and the activities which are conducted by ICOG. ICOG was founded way back in 1984 as an academic wing of our federation. So this year we complete 40 years and we are entering the 41st year in Jan. Currently, we have around 2,400 total fellows and there are nearly 200 members. The mission with which ICOG was started was with an objective of establishing the college to promote education, training, research, and spread of knowledge in the field of obstetrics, gynecology, reproductive health, family welfare, and related areas. The vision of ICOG is to strive for advancement of standard of education and quality healthcare practices throughout the country. And the college encourages safe, ethical OBGY practice for patients' benefit. I must acknowledge the past chairpersons who have brought ICOG to where it is today. Because of these eminent personalities, ICOG is what it is as of now. This is the team ICOG 2024. Special thanks to all of them for allowing us to conduct this particular program. And I must appreciate work done by my 25 very enthusiastic governing council members who are senior practitioners, and half of them are senior professors in various medical colleges. Coming to the administrative activities of ICOG, the first and foremost is ICOG credit points. The question arises in our mind, what is the role of having ICOG credit points? So currently, the ICOG credit points are useful when you wish to become a fellow of ICOG, and we do allot 1 credit point for a 2-hour program. A full day conference will get around 5 programs. A 2-day program will have about 10 points. One has to accumulate at least 100 points over a span of 3 years if he or she doesn't have adequate number of publications. So it is a waiver for publications as far as the ICOG fellowship is concerned. So for all FOXY affiliated societies and committees, the ICOG credit points are given free of charge. So my appeal to all the presidents and secretaries sitting here in the program today, that whenever you have any small CME or a big conference, don't forget to apply for ICOG credit points. It is just, we are just an email away. If you send us an email with detailed scientific program, we will revert in 1 or 2 working days. So all state level OBGY societies, all medical colleges, and other organizations like RCOG, FIGO, SAFOG, AOFOG will get ICOG credit points for free. And of course, for other organizations which are not directly related to FOXY, the points are available against a small payment. Each year, ICOG invites applications from various FOXY societies to host ICOG CME. So every year we conduct around 20 CMEs. So again, an appeal to all the presidents and secretaries who are sitting here, if you are keen to have one ICOG CME, do write to us and for the year 2025, and we will certainly grant CME. There's a certain funding which is associated with it. So for a 1-day CME, ICOG funds around 25,000 rupees, and for a 2-day CME, 50,000 are given. You just need to click the ICOGonline.org, and here you will have the prescribed application form and the guidelines on which the program is to be arranged. So once the application is sent to the office, it is scrutinized by the office bearers, and after sanctioning the CME, 50% of advance payment will be made to the society. And once we receive the report and necessary photographs, the rest of the payment is done. And this is done rather quickly. ICOG training certificate training courses are something which are very, very popular. And we have around 42 centers throughout the country who are imparting knowledge for reproductive medicine. We do have centers from Tamil Nadu. So we have centers from Chennai. We have center from even Nagarcoil. Dr. Sundar himself has one center where the training is being imparted on gynae endoscopy as well. Vaginal surgery, critical care in obstetrics, ultrasound, and of course, fetal medicine are the new areas where we are giving training for about 6 months. This year, we have started a fellowship program in reproductive medicine, gynecological endoscopy, and fetal medicine, where these centers are imparting training to candidates for a period of 1 year. And why we thought of doing it is especially for reproductive medicine, so that we can have a sufficient number of cases which are mandatory as per the ART law. And I'm happy to say that we are getting a very good response for these 1-year fellowship programs from candidates who have recently passed their post-graduation. The ICOG online centralized lecture series is something which is again a very popular program. And I must appreciate efforts put in by the course coordinators, Dr. Pratik Tambe, Dr. Seema, Poonam Goyal, Shalini, who are the course coordinators for reproductive medicine. For endoscopy, we have Dr. Dinesh Kansal, Renu Singh Gehlot, Mala Raj, and Subhash Malya. And for fetal medicine, we have Dr. Chinmay Rath, Vandana Bansal, Bela Bhatt, and Pragya Mishra, who are the course coordinators. We do have lecture programs every week. So all our coordinators sit there throughout the program and interact with the candidates. We also have case presentations by ICOG candidates because these are the youngsters who are seeking specialty training and they are supposed to present cases even at the time of their exams. So we are training them as well. The advantage of the online central series is candidates get an exposure to experts all across the country, and there's uniform teaching for all our candidates. So this is a program in nutshell. This is how the program looks like, where for reproductive medicine, we have every Monday and Wednesday program for almost 2.5 to 3 hours, where we have case presentation by candidates, and there are 2 lectures of 30 minutes each by various experts all across the country. Once a week, we conduct lecture series for gynecological endoscopy, and these are who's who as far as gynae endoscopy is concerned. And similarly, for fetal medicine, we have once a week program where case presentation and lecture is combined. ICOG fellowship and membership, we are now just a click away. There was a time when we used to ask everybody to send a physical form along with certificate copies. So it used to be a big bunch, but now we are just a click away. And this is a click. You just have to visit the ICOG website, and these clicks are there for you for perusal and help. The ICOG convocation, the next one will be during the AICOG 2025 in Mumbai, but the applications are now closed. So those who are interested in becoming a fellow, the lines are open till 15th of February, and we will have convocation on the 1st of March 2025 during the annual ICOG conference, which will be held at Pune. What are the criteria for fellowship? So a doctor should be holding a postgraduate qualification for at least 10 years, membership of FOXY for at least 5 years, 3 publications in any reputed journal or FOXY focus in last 10 years. And if you don't have any publications, one can always have the 100 ICOG credit points accumulated over a span of 3 years. Attendance of 2 FOXY sponsored conferences is important, and there are so many events that are taking place throughout the country. You can certainly attend national level conferences to become a fellow. And if you have a certificate of presentation of 2 papers in any of the national or international or even state level conferences, we accept it very well. And then if you have a faculty certificate in any of these conferences, you are welcome to apply. For younger members, we do have MICOG, where younger members have to fulfill certain criteria and become members. We are still working on the mechanism where we can convert MICOG to the fellowship of ICOG at a later date. Coming to the scientific activities of ICOG, and one of the most prestigious event is FOXY ICOG Dr. C.L. Jhaveri Endowment Symposium, which is conducted every year during AICOG. And this is dedicated to late Dr. C.L. Jhaveri, who was the founder chairman of ICOG. We have 5 speakers who are essentially fellows of ICOGs, and the topics are related to the current official theme of FOXY. And we ask them to speak for about 15 minutes, and there is a special felicitation at the end of the scientific program. Dr. C.S. Don was the second chairman of ICOG, and we have an oration dedicated to him called ICOG Dr. C.S. Don oration, and it is delivered by immediate past chairperson of ICOG, and generally it is delivered during the ICOG annual conference. Dr. Usha Saraiya was also a past ICOG chairman and past president of FOXY, and through her generous donations, we have started this oration called ICOG Dr. Usha Saraiya Oration. Dr. Saraiya is known for her contribution to the field of gynecological oncology. So every year, usually in the month of February or March, we invite applications. So those are attendees who are working in the field of gynae oncology, and if you are a fellow of ICOG, please apply for this oration. And the societies of ICOG, the societies of FOXY, they can be host to this particular oration. There are specific criteria for the orator, where we expect you to send your original contribution in the subject of gynae oncology. And once we receive the write-ups, we discuss it amongst the office bearers of ICOG. And of course, Dr. Saraiya also gives her valuable tips. The ICOG Professor Krishnendu Gupta Conference Oration on Women's Health was started in 2018. And this is dedicated to Professor Krishnendu Gupta from Kolkata, who is the past chairperson of ICOG. And this is again something which is an important part of the annual ICOG conference, and the orator has to speak on any aspect related to the subject of women's health. The newest oration to be added is the ICOG RRR oration, and thanks to Dr. Lakshmi Shrikande and her team who donated through the RRR conference, which was held during Dr. Lakshmi's tenure as chairperson, and this is delivered by the sitting chairperson of ICOG during the ICOG conference. ICOG is actually known for its web-based activities. So we do have yearly programs going on in the form of web series. ICOG PG Gurukul is something which was started about 3 or 4 years ago, and this is taking place twice a month. So this is something for the postgraduate students, where they do get an exposure to meet senior professors, and they can attend the mock exams which are conducted through this program. We do have the FOXY ICOG Jogi Research Methodology and Journal Club, where we address 2 new articles, and we have some excellent discussion during this program. The FOXY ICOG webinar on family planning, ICOG masterclass, which is currently taking place once a month. We intend to increase the frequency to maybe 2 or 3 times a month. The FOXY ICOG PG clinic, which takes place on the second Sunday of every month. Here, as per the NMC norms, we have planned certain activities for the candidates. Of course, there's a mock viva as well. The advantage of this program is that the candidate or the students, the PG students, get an exposure to various faculty sitting at their own hospital or at their own homes. This year we started ICOG, the case I shall never forget, and we've had some excellent speakers in the past. The ICOG New Frontiers, which is taking place every alternate month. The ICOG online certificate courses, which take place for about 3 days every month on a specific subject. And this is something which is extremely popular these days. Of course, you have to attend all 3 days. There is pre-test and post-test, and you need to score at least 50% marks in the post-test. If you attend all 3 days with more than 50% marks, you do receive the certificate of completion of these online course. For professors who are sitting here in the audience today, they can certainly apply for ICOG visiting professorship. Again, this is something which will again be announced in the month of February, and you can apply to the ICOG. If the society wishes to host any professors do get in touch with us once you receive this email from the office, possibly in the month of February. For young fellows of ICOG who are under 40 and those who wish to take short-term training for about 2 to 4 weeks anywhere in India, we do have ICOG Impure Pharma Travel Award, and this is to encourage our young OBGYNs. A quick mention about the ICOG elections. So we have this year, in the year 2025, we'll have election for the post of secretary, and there are specific criteria for post of secretary. And we have 25 governing council members who will have a tenure for 2 years. And alternate year, we'll have an election for vice chairperson elect. Again, somebody who's eligible to apply for this post may consider so. What are the benefits of becoming ICOG fellow and member? Only fellow is eligible to start ICOG certificate courses training 6 months and now 1 year. For that, you have to be a fellow and you have to complete 3 years after the fellowship. Youngsters can apply for the MCure Travel Award. All the professors can apply for the visiting professorships, and you can certainly apply for the oration and be part of various ICOG sessions, ICOG CME, and even Dr. C.L. Javeri ICOG symposium during the AICOG. And for all this information is there, we are just a click away. Please don't forget the email IDs, because whatever queries you have, you can always get in touch with me or Dr. Pratik or Dr. Charmila, who are here today, or you can send an email to the office. And I take this opportunity to invite you to Pune on the 1st and 2nd of March 2025 for the FOXY ICOG annual conference, that is updates in OBGYN. Thank you very much. And once again, thank you all the Tamil Nadu and Pondicherry OBGYN societies. Thank you, Charmila. I hope she joins by the end of the program. She's busy in a workshop in Mumbai, and special appreciation to Madhu, who's done a lot of hard work for this program. Thank you.
Thank you so much, sir, for this clear elaboration of what ICOG has to offer. And Shanta Babala ma'am, any queries, ma'am? I think ma'am's.
Yes,
Ma'am, any
good
queries?
evening.
Good
Yes,
evening.
ma'am. Good evening, one and all present here. First of all, I should thank the organizers for this, for involving me in this wonderful evening, this session. So I'm much honored to be present here in this among all the topmost office bearers of FOXY. So that was very insightful, sir. There was an elaborate discussion regarding know your ICOG. So I think that I can take up all these, implement all these facts in our society to improvise our postgraduate students' performance also. Thank you so much, sir. And that was very much enlightening regarding ICOG, all those online possibilities of online program fellowships, certificates, and all those things. We were very much aware, and I could definitely take down to all my society members to get benefit out of this. Thank you.
Yeah, thank you. And the programs which are now, I must say that the ICOG PG clinics and ICOG Gurukul are the programs which are now time tested. They were started during COVID times, and they have been very, very popular. And day by day, we try and improvise. So the current PG clinic program is purely based on the recommendations of NMC. So what NMC wants during for the postgraduate exam, that is what exactly we are trying to do. So it will be sort of a rehearsal for the young postgraduate students who are doing their post-graduation. So they get an opportunity to interact with various examiners totally from different cities or even different states.
Yes, sir. Yes, sir. Thank you so much.
Thank you. Thank you so much, sir. Thanks a lot for enlightening us about the tremendous work ICOG is doing. And thank you, sir, once again.
Yes, thank you, sir. It's a pleasure to have you with us.
Sure. Sir.
Thank you, sir. So, moving on to the next session. A small change. We'll be having the third session now as Dr. Lata ma'am, she has a meeting at 8 o'clock. So, moving on to the third session. Gauri, can I have the CV slides of Dr. Rashmi and Dr. Jasmine, please? Next. Okay. So, for the third session, we have our chairpersons. Dr. Rashmi Ajit, who's the secretary of Nagarkoil Obstetric and Gynecological Society, and Dr. Jasmine, who's the secretary of Thoothukudi Obstetric and Gynecological Society. And can you please introduce? I think Rashmi ma'am is in an emergency cesarean section. Jasmine ma'am, can you please introduce Pratik sir? No,
Yeah,
I mean,
ma'am.
sorry, Lata ma'am. Lata ma'am, CV, please. Gauri.
Hello. Am I audible, ma'am?
Yes, ma'am, you're audible, ma'am. Gauri, can I have Lata ma'am CV, please? Yes, the next CV, please. Yes. Yes. Yes, ma'am.
Thank you so much, ICOG, for giving us the opportunity. Yeah, Dr. Lata Chaturvedila, Professor of OG, JIPMER Pondicherry. She had been the Faculty of Medical Education at JIPMER, President, Obstetric and Gynecological Society of Pondicherry, and Executive MBA, FICOG. Have 2 ICMR funded projects, COVID and pregnancy.
I think that's okay,
Areas-
ma'am.
Her areas of interest are high-risk obstetrics, preventive oncology, and fertility. She has passion for normal deliveries. She was a guide for the past 24 years. Many publications and some chapters in books. Over to you, ma'am.
First of all, good evening and thank you. I should thank Dr. Charmila. 1 second. Can I share? Yeah. Dr. Charmila, Dr. Parag, and of course Madhumita for giving me this opportunity. When I was asked to talk on some topic, I thought nothing more than something which can really reduce cesarean section rates. So I chose this topic on external cephalic version, which I'm sure every obstetrician should do before taking up any patient with breech presentation or transverse life for elective cesarean sections. So I bring greetings from Pondicherry. So the topic is external cephalic version. Now, what is external cephalic version? I hope there are postgraduates who are listening because it's a topic very important for them. It's conversion from any malpresentation, that is breech or transverse life, to a cephalic presentation. Right. So the prerequisites for an external cephalic version, first of all, it should be a breech or transverse lie at term. Obviously, it has to be a live baby. We don't have to do it for a dead baby. Pelvis should be adequate. This is something very important. No point doing ECV and then finding out there's a gross contraction in the pelvis. So that is very important. Leica should be average. Ideal would be 7, but AFI of 5 or more is still okay. And it's necessary that we take consent or written consent. And we should also tell that ECV doesn't mean 100% success or 100% vaginal delivery rate. We should also tell them that at least it is successful and you can have a good vaginal delivery. Going to the contraindications, we have absolute contraindications like placenta previa and multiple pregnancies obviously cannot be done. And relative uterine anomalies, if there is a bicornuate uterus or septate, obviously, or unicornuate uterus, it will be difficult to do. If it's just an arcuate uterus, it's definitely possible. Oligohydramnios, I mean, Leica of less than 5. Fetal growth restriction, rupture of membranes, or hypertension, that too mild is without severe features is okay, but severe features, yes, we would definitely avoid doing an external cephalic version. So if I look at the technique, the success is better if it is done at 37 weeks. In a primigravida, we can even try at 36 weeks. No point doing earlier than that because definitely baby will revert back. First of all, we need to assess the fetal position like her, and as I said, ideal would be above 8, but between 5 to 7 we can try. fetal position definitely makes a difference, which I'll be telling later. It's always good to give tocolysis with injection terbinafine, 250 micrograms subcutaneous, 10 to 15 minutes before the procedure. Only problem now is terbinafine is not available, so we do face problems about relaxation of the uterus. Then we perform the version, which is always a somersault. In occasional cases, we can do even reverse somersault, that I'll come to a bit later. If the woman is having RH incompatibility, then preferably give anti-D if she is already not received at 28 weeks. And how many times can we attempt version? It is at least 2 to 3 times before we give up. It's not immediately. Maybe with a gap of 24 hours or 48 hours, we can definitely do version 2 to 3 times. Coming to success rates, PCV is almost successful in around 60% of cases. Of that, at least 60% would have had successful vaginal delivery. So we can really bring down the cesarean section rates at least by 50% in patients with breech or transverse line. Previous cesarean section is definitely not a contraindication. I'm saying previous one cesarean section, previous 2 cesarean sections, there's no doubt because we don't really allow vaginal deliveries. And early labor also we can try. Early when I say when it is, the patient is not really in active labor around 75% of phase 3 to 4 centimeters, we can try, provided the breech has not gone into the pelvis. So I would like to just show a small video. About what we'll do. First of all, we do an ultrasound to see, confirm where the back is, where the placenta is, which is all very important for an external cephalic version. So the back is on the left side. And look at the cardiac activity. That is also very important because we need to keep monitoring the fetal heart as we are doing external cephalic version. The type of breech is also important because if it's a complete breech, the version will be much easier. So this is what we are doing. With the left hand, hold the head, and with the right hand, we hold the breech. Because the back is on the left side, we are trying to do a somersault. Easy to turn whichever side the limbs are. So don't be harsh, be gentle, and it will definitely turn. So after certain halfway through, then we may have to change hands because if you have to cross the hands, it will be difficult to turn. This is how we gently do the version. The head keeps slipping, so we'll have to keep constant pressure on the head. And many times you can make out that head has turned. See, it's nicely turned. Sometimes clinically itself you can make out. So what was breech has now become cephalic. The good fetal heart. So it's important to see the fetal heart after we do a version because sometimes there may be some bradycardia, especially if the loop is small. So just to show that the head has turned, definitely turned. We do have a lot of patients coming to us asking for external cephalic version. Yeah. So when does ECV fail? When there is polyhydramnios, definitely yes. Sometimes it's successful, but yeah, most of the times if it is polyhydramnios, it's not just excess liquor. Suppose the liquor is around 16, 17, it may still turn. But polyhydramnios, when I say if it is more, AFI is more than 25 or a single vertical pocket is more than 8, the chances of it reverting back is high. Primi gravida, especially their abdominal tone will be really increased. So extended breech, again extended breech because the head gets splintered by the feet. So it's difficult to actually grip the head of the baby. Then again it will fail. When the back is posterior or anterior, it's very comfortable if the back is on one of the sides, either the left side or right side. The main problem why it doesn't turn if the back is anterior or posterior is just getting the grip of the head, which is very, very important. obese women, obviously obese abdomen with lot of fat. It's all about getting a grip. Big babies also we find difficulties in turning. As I said, we can try at least two. It's not that we should not try in all these. Definitely you should try. But failure rates are much higher before claiming failure. Of course, in our place, even senior residents do. We can go by hierarchy. If someone fails, the other person can try. But just 2 to 3 times it can be tried. It's a gap of 24 to 48 hours. Provided you have time to wait. So again, I'll just show another video to show how easy sometimes it is. You can see how the hand is easily moving. So nicely, it just moves. Yeah. So this happens especially if multis or when women are really motivated for external cephalic version, it really turns. It gives a lot of satisfaction both for the patient and also for the doctors, because most of them will end up in a good vaginal delivery. So that is to show how easy it is sometimes to do. It's not easy always. As I told in pre-get the Jipmer statistics between 2011 to 17, after that I don't have the statistics done. We had around 611 ECVs, of which 414 turned, that means almost 70.4%. And we had adverse events in 2.6% of the patients, like abruption and cord prolapse. Luckily, we didn't lose any baby. So these were transient fetal heart abnormalities, premature rupture of membranes, fetal distress requiring immediate delivery in 2 cases, abruption and cord presentation. So we have to look out for it. As I told earlier, these are the complications which can occur if with external cephalic version. So again, one more video again to show it is easy. I think I don't want to repeat it. It is again to show how easy. So another thing what we can do is reverse somersault, especially if it's a transverse lie. If you have to take, almost a 180-degree rotation, it may become very difficult. So in those cases, you can just turn the baby to 90 degrees. If the entire 180 degrees is becoming difficult, even that is quite successful. So a reverse somersault, usually we can do it in transverse lie, provided the proper somersault doesn't really be helpful or doesn't occur. So after a successful ECV, we had 20.1% of women who underwent cesarean section. Some months we have even had 95% of ECVs who delivered vaginally. As I said, previous cesarean section is not a contraindication for CV. In previous cesarean section, we attempted around 38 cases in those periods. 84% were successful, 59% deliver vaginally with no complications. So that's a big achievement in previous cesarean section. So one of the ways we can really reduce cesarean section rate is doing an external cephalic version. But of course, it is not without complications. While doing so, you can have premature rupture of membranes, in which case you have to abandon the procedure, provided the premature rupture of membranes has occurred after the this thing, then you can, if premature rupture of membranes has occurred after we have done the version, then it is okay. Still, you can continue. I mean, you can allow vaginal delivery. But if it has occurred before, then you have to obviously abandon the procedure. If there is abruption, then if there are any fetal heart decelerations, you have to either revert back, or if it is not possible, then we may have to take her up for cesarean section. Cord prolapse. These are the complications which can occur with external cephalic version, known complications. So the take-home message I would like to give is, should try external cephalic version in all patients with breech presentation, provided there are no contraindications. Counseling the patients regarding success of vaginal delivery is very important. I tell you, most of the patients are very happy going through it. But yes, sometimes they are disheartened if, external cephalic version doesn't occur because they were anticipating vaginal delivery. Having said that, in a breech, with an average sized baby, with a good flexed head, and the pelvis is adequate, especially multis, we can always allow even a vaginal breech delivery. Even that should be counseled when we are doing counseling for external cephalic version. Many of the patients have agreed for vaginal breech deliveries, especially in multis, and it has been very successful. So thank you for this short. This is what I wanted to stress. So no breech should go without an external cephalic version. Thank you. Thank you once again.
Thank you so much for that very positive outlook on external cephalic version, ma'am. Jasmine, ma'am, can you give your concluding remarks, please, ma'am? Ma'am, you're muted, ma'am. Jasmine, ma'am, you're muted, ma'am.
Am I audible, ma'am?
Yeah.
Thank you, Dr. Lata, for the excellent presentation on external cephalic version. We are really excited to hear that so many external cephalic versions which have turned positive and they successfully conducted vaginal delivery, most commonly 70%, and very less incidence of accidents at 2.6%. Really, it is a very great thing you have achieved. And it is, can you please post these slides for the purpose of our postgraduates, ma'am?
Yeah, I will.
Yeah.
Yeah, sure.
This is a very useful and much, I mean, concern over the patient, I think you had got, because a doctor trying an external cephalic version in this era is really appreciable. And thank you so much, ma'am.
I just want to say, I mean, we get a lot of patients to JIPMA just because they want vaginal delivery, whether it is external cephalic version or whether it is previous cesareans. Our rate of, previous cesarean sections are so high, and in primary, and they come back here when we ask, no, we want vaginal delivery. So we are happy to do that, but we have to try and bring down the primary cesarean section rates to avoid this.
Yeah,
So
ma'am.
that
Yeah,
is
ma'am.
one
Absolutely
topic
true.
which I always
Absolutely
like.
true. Okay.
Thank you. Thank
Okay.
you so much.
Thank you so much.
Yes, ma'am. Thank you so much, ma'am. Now moving on to the last session. We have our chairpersons. Gauri, can you please share the CV slides? Gauri? Yeah. So, yes. So for the third talk, we have a chairpersons. Dr. Mahalakshmi, who's the president of Madurai Obstetric and Gynecological Society, and Dr. Sujata, who's the president of Tirunelveli Obstetric and Gynecological Society. I request Mahalakshmi, ma'am, can you introduce Pratik Tambe, sir?
Oh, sure.
Yes.
Thank you. Thank you, Dr. Pratik, sir, Dr. Sharmila, madam, Dr. Pratik Tambe, sir, and Dr. Madhumita for all here, and the topmost list of ICOG faculties. We thank for all the organizers who have given me this opportunity. Pratik Tambe, sir, is known to me quite for the past more than 15 years, and sir has visited Madurai OG Society twice, as far as I know. And he is the governing council member of ICOG in the year 21-25, governing council member for the reproductive medicine also, and a patron of managing council member of Mumbai OG Society, managing committee member of Indian Society of Assisted Reproduction, as well as ISAR and Foxy Endocrinology Committee. He has holded so many laurels of awards, as well as having the post of prestigious post in many committees. And he is the editor of 30 books and 4 Foxy focuses and handbooks and 11 key practice points. He has contributed more than 100 plus chapters and is an invited faculty and organized more than 800 CMEs. He is the convener of the ICOG Reproductive Medicine course in the year 21-25 and a peer reviewer of Journal of OG Society of India. Over to you, sir. Now, sir is the ERT consultant and gynec endoscopic surgeon at Ashirvad IVF Mumbai. Over to you, sir, to talk on a very much awaited talk on gestational diabetes. It may be a gestational or a over diabetic. India being the capital of diabetes, it is a much awaited to know the recent updates in diabetes also. Over to you, sir.
Thank you very much. Let me begin by expressing my gratitude to the ICOG office bearers, Chairperson Dr. Pavel Kotadawala, Vice Chair-elect Dr. Parag Biniwale, Secretary Dr. Sarita Bhalirao, and the conveners for this program, Dr. Charmila, Dr. Madhumita, who has been doing excellent work behind the scenes organizing this program. Today being World Diabetes Day, I thought it would be pertinent to speak a little bit about gestational diabetes mellitus. We will try and focus on the delivery considerations, but before I go to the most important part, which is the delivery, I'll also briefly have an overview regarding gestational and pre-gestational diabetes. So is this subject relevant in clinical practice? I think it's already been answered. Today is World Diabetes Day, and on the occasion of World Diabetes Day, the Guardian newspaper in the UK presented the most recent Lancet paper on the prevalence of diabetes throughout the world. And it's been found that 800 million people throughout the world now have diabetes, of which 212 million are here in India. India is the country which contributes about 26% of diabetics to the world. We are the world leader in diabetes population. So obviously at some point of time, these women are going to get pregnant if they have pre-gestational diabetes. If they don't have diabetes, when they get pregnant, it is going to get unmasked, and it is going to be you and I, the OBGYNs, who are going to identify it, hopefully, and treat it in an appropriate fashion. We also know that gestational diabetes is a harbinger of the vicious cycle of diabetes. You know that mothers who have diabetes during pregnancy, thanks to the Parker hypothesis, you know that the baby that is born is also going to have fetal origin of this adult disease. There's going to be epigenetic programming, and diabetes, cardiovascular disease, and obesity are something which is a near perfect trifecta of NCDs which the world is today suffering from. In fact, the United Nations MDG goals say that 15% of all pregnancies exhibit hyperglycemia in pregnancy, and about 84% of these are GDM. The remaining are pre-gestational diabetes, which we will come to during the course of this talk. There are multiple guidelines which have been issued over the years from different organizations. First, we had the Government of India guidelines published in 2014. These were updated in 2018. These are freely available on the internet as well as in the Ministry of Health and Family Welfare website. In case you don't find them, please feel free to write to me by email. I will be happy to share a copy with you by email. The National Institute of Clinical Excellence, that's the NICE, also updated its guideline in December 2020, just around the time of the COVID pandemic, and these are very good guidelines. ACOG came out with a practice bulletin number 190 in 2018, and there are numerous other small papers as well, which I will be referring to during the course of this lecture. Remember, as far as relevance to Indian clinical scenario is concerned, the last word is usually DIPSI, which is the Diagnosis and Management of Diabetes in Pregnancy India Group, known as DIPSI for short, and they published their guidelines in 2021. We know that there are multiple obstetric issues which are associated with gestational diabetes mellitus, and this is a beautiful paper in 2022 which looked at all the different pathophysiology and the consequent complications, both from the maternal as well as the fetal point of view. We know that the complications that we face are typically when the patient presents late, the diagnosis has been missed, or she has not had the requisite antenatal care. And this includes polyhydramnios, preeclampsia, eclampsia, abruption, preterm labor, preterm deliveries, NICU admissions, cesarean deliveries, and of course, postpartum hemorrhage. It is beyond the scope of today's 15 to 20-minute talk to talk about each of these complications. I'm just going to quickly rush through these slides because this is an August audience and you're aware of all these issues. What I want to focus on is primarily the detection part and finally the translation into how to have a successful term birth in these babies who are very much at risk. The known fetal issues, as you know, congenital anomalies are significantly more prevalent in this population, especially if in the first trimester diabetes has not been detected. And of course, post-delivery, we know that hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia And of course, the delivery complications like shoulder dystocia, brachial plexus injury, all of these are significantly more common. The BMJ in 2022 came up with a beautiful systematic review and meta-analysis. Remember, this is the British Medical Journal. It's not an OBGYN journal. They will not write about obstetric issues unless it is something of significant import for general practice and for laypersons to know about it as well. And they came up with this beautiful, what I call visual abstract, which should be there in every single paper that we read, because at a glance, it tells you everything that you need to know without reading the entire paper. They have looked at 75 lakh pregnancies and they found that if insulin was not used, the incidence of cesarean section, preterm delivery, low Apgar scores, LGA babies, as well as SGA babies was significant. Therefore, according to them, insulin is the one drug which we should be using more and more to reduce the complications that we encounter. Can we educate women regarding the primary prevention? Yes, especially if we try and address before pregnancy all these issues. But that's something which probably is of relevance in a major metro city or in Western civilization. The vast majority of Indian women don't really plan their pregnancies and they don't optimize their pre-pregnancy health before they choose to get pregnant. How do we identify women with HIP? We know that there are standardized tests which are available. The traditional approach has been to use high risk population screening, which is not relevant in India because Indian women have an 11-fold increased risk of developing GDM as compared to their Western counterparts. And therefore, the current recommendation is to perform universal screening. The highest progression of type 2 diabetes is seen in South Asians, which is us, Indians, and we've just seen the Guardian newspaper talk about 200 million plus Indians contributing the largest population of diabetics in the world. We don't do risk-based screening for reasons we've already covered. And Cochrane in 2014 came out with strong evidence that treating GDM is beneficial, improves outcomes, and enhances the fetal survivability and good take-home baby rates. The best screening test is the single-step, single-value WHO/DIPSI test, where you look at the 2-hour value of glucose after performing a 75-gram glucose load. If your value is between 140 to 200, that is gestational diabetes. If it is more than 200, that is frank diabetes, which is first being unmasked or diagnosed in pregnancy. The Government of India algorithm regarding universal testing is there in the guideline, which I alluded to earlier. If you can't find it again, feel free to write to me. I will share it with you. Ideally, you do it first at the first antenatal visit. You repeat it at 24 to 28 weeks. And some of us are now even repeating it once more at around 35 weeks just before the patient is going into labor. How do you manage once it's diagnosed? This is the standard algorithm with medical nutrition therapy. But a word of caution here, insulin is probably the best way to control, especially if you have multiple antecedent high risk factors in these women. Especially, I deal with a lot of elderly women. By elderly, I mean they're more than 35 when they first get pregnant. They are usually infertility conceptions. Infertility women have a lot of obesity. They have silent hypertension, they have silent diabetes, which is often not diagnosed. And all of this means they are very good candidates for insulin therapy. The Government of India guidelines also talk about patient education regarding hypoglycemia, which we all should educate our patients. Metformin, according to Western literature, is not recommended, and the RCOG guidelines say that you can recommend it for certain groups of women. The GOI guideline, which was updated in 2018, says either metformin or insulin is the accepted medical management. Insulin is the first drug of choice, and metformin can be considered after 20 weeks for medical management. Again, remember that a regular follow-up, multidisciplinary care should be the order of the day. If there aren't enough facilities, then the woman should be referred probably to a higher center, preferably tertiary care. Now we come to the delivery considerations, which are all important to ensure good take-home babies and to ensure that we have a least incidence of complications. The Government of India guidelines published in 2018 say if it's a well-controlled gestational diabetic, then induction of labor should be scheduled at or just after 39 weeks. If you find that there is poor blood sugar control, high risk factors like hypertension, is previous stillbirth, other complications, then you need to deliver earlier. Don't wait till 39 weeks. Vaginal delivery should be preferred. Cesarean is only to be done for obstetric indications. So not all diabetics necessarily need a cesarean section. If you have fetal macrosomia, which means an estimated fetal weight of more than 4 kg, then a primary cesarean section should be considered. This is the only indication that the GO guidelines mention for a primary cesarean section. And this also should be done at 39 weeks because we know that if you terminate a pregnancy too early, the baby can end up with respiratory distress or transient tachypnea of newborn, and you will have an unnecessary NICU admission. What do the NICE guidelines say? The NICE guidelines say women who have type 1 or type 2 diabetes with no complications, elective birth by induction of labor or if indicated, which means an obstetric indication, then cesarean section between 37 and 39 weeks. Elective birth before 37 weeks only for women who have metabolic or other maternal or fetal complications. Obviously, for this, the woman will need to be admitted, will need to be regularly followed up, and she will need multidisciplinary care with good coordination with the neonatologist and the NICU staff. Women with gestational diabetes should not deliver any later than 40 plus 6 weeks because the incidence of complications like sudden IUFTs and meconium strained amniotic fluid are significantly higher. Women should be delivered before 40 plus 6 weeks if they have maternal or fetal complications. Those women who have an ultrasound diagnosed macrosomic fetus, this is a very important step. You need to explain to them the risks and benefits of various modes of delivery. And at that moment of time, should so choose to undergo an elective abdominal delivery, this must be respected, this has to be documented, and then you can schedule the delivery accordingly. What does the American College say? American College says well-controlled GDM with diet and exercise delivery should be considered at 39 weeks, which is similar to what the GOI says and which RCOG also says. Women who require medications and they are well controlled deliver between 39 and 40 weeks. If you have poor control of GDM, then you can plan delivery earlier, but you need to take into account the other factors as well. The presence of hypertensive disorders, comorbidities, non-reactive MST, all of these are going to change your delivery time. How do you actually monitor a woman with gestational diabetes during labor? Continuous intrapartum monitoring would be ideal. 1:1 standard nursing care is what is described in the textbooks, but it is not going to be practical in most Indian centers. But what is practical is to ensure that you have your glucose, which is being in the therapeutic range throughout labor. So the morning dose of insulin or metformin is to be withheld, and then you need to start them on too early monitoring with hemoglucose sticks. And then according to the level of the blood sugar, you can adjust the amount of insulin in your 500 ml of normal saline and make sure that it goes at 16 drops per minute for 100 ml per hour. You don't need an infusion pump. It's only 16 macro drops. You can easily titrate the dosage. How do you counsel women post-delivery? You need to ensure that you follow up these women and they should be seen ideally by a consultant. You can repeat the OGTT at 6 weeks. This is as per the GOI guidelines. And then interpretation is similar to what we saw earlier with the single step, single value. Counseling, lifestyle, diet, exercise, but most importantly, ensure that you have conveyed that they have a significantly higher risk of developing frank diabetes at some point in the future. NICE guidelines say do an FBS at 13 weeks, no need for OGTT, and refer to the diabetes prevention program if they are eligible. Now I'm going to come to the last part of the talk, and here I'm going to talk about some of the new evidence in the new papers that have just come to light in the past couple of years. First of these is about pre-gestational diabetes, And I found this beautiful systematic review, which is published from South Africa in August of 2022. They looked at 20 studies and nearly 2 lakh women, and they found that adverse outcomes with maternal diabetes are significantly more in women who have pre-gestational diabetes as compared to gestational diabetes mellitus, which means type 2 DM or type 1 DM, which has not been diagnosed before pregnancy. Obviously, that's not rocket science, but significantly, they have said that 13 perinatal complications, including cesarean section, preterm birth, congenital anomalies, preeclampsia, neonatal hypoglycemia, macrosomia, NICU admission, stillbirth, poor APGAR scores, all of these are significantly higher, which means we need to pick up these women early. That is why you do your DIPSI in the very first visit, irrespective of what the gestational age is. Another question that we need to address is whether complications are more common in diet controlled GDM. And for this, we have a paper which was published in BMC Pregnancy and Childbirth. This is a single center study published in April of 2022. 1,000 participants, and they found that the cesarean section rate at 41 weeks or more was significantly higher, and vaginal delivery rates were much more at 39 to 40 weeks as compared to 40 to 41 weeks, which again is in line with what the NICE guidelines say, but don't allow these women to go more than 40 or 41 weeks, try and terminate them at 39 weeks. And that's exactly what they have said. More to the point, if you want to encourage vaginal birth in this high risk group of women, they have identified that women who have Bishop scores higher than 4 can undergo an iatrogenic intervention at 39 to 40 weeks. And in women who are unfavorable, which means the Bishop is less than 4, then you need to have a guarded prognosis and counsel the patient and her caregivers accordingly. $1 million question, can we reduce primary cesarean section rates, especially in a woman with GDM? You've just seen a fantastic presentation on ECV, just by the preceding speaker. I have this paper which was published in the American Journal in November of 2023. What they've said is you can have a prediction model, just like you have AI, which we use in ART now to identify the best embryo, which has the greatest implantation potential. Similarly, you can also have an AI model which can predict cesarean section. This is published just last year in November of 2023. And they looked at nearly 5,000 pregnancies, of which 1,375 were excluded. So they had 3,500 plus remaining. And they looked at 24 different predictor variables. And of these, 8 were the most important. And these are those 8: whether insulin was required, whether the woman had hypertensive disorders of pregnancy, whether she had macrosomia, what was her early pregnancy BMI or ideally a pre-pregnancy BMI, nulliparity, polyhydramnios, maternal age, and her first HbA1c value. If you take these 8 parameters and put them in the software, it will give you the likelihood of a cesarean birth in that woman. There are multiple other things also which we can discuss. Shoulder dystocia is a half an hour discussion by itself. Difficulties during cesarean section. I'm not saying that cesarean section in a macrosomic baby with an obese diabetic mother is an easy task. That is a discussion by itself. And the neonatal complications, of course, is something which we almost never talk about, but we need to be aware of and we need to communicate to the patient and her family as well. So I'll close with a few simple take-home messages. HIP or hyperglycemia in pregnancy is increasingly being encountered. India is the diabetes capital of the world with 200 million sufferers. Some of these women are going to get pregnant at some point. They are going to present to you either with pre-gestational diabetes or diabetes which is first unmasked in pregnancy. Trial of medical nutrition therapy is required. Universal screening always, insulin or metformin, depending on what exactly are her sugar levels. Insulin gives you much better, stricter control, lowers complication rate, especially in the populations that I cater to. Your mileage, of course, is going to vary. Delivery timing and mode has to be individualized in line with either GOI, RCOG, NICE, or the ACOG guidelines. And all important, once she is delivered and gone home, you need to counsel her regarding the progression to type 2 diabetes. Thank you very much for a patient hearing. And thank you for this opportunity, ICOG and the office bearers, to speak in this wonderful field.
Thank you so much for that very informative talk on considerations, sir. That was a wonderful session. So, Mahalakshmi ma'am, can we have your concluding remarks?
Yes, sir. Sir, that was an excellent lecture, sir. Sir, only one question, sir. That
Yes.
is during the third trimester, when the patient has macrosomia, the metabolic is upset. That has led to macrosomia. How are you going to tide over the chances of complications during inducing the labor or during anesthesia induction? Whatever may be, the brunt may go either to the physician or to the anesthetist because the metabolic profile has
So
been
the
changed.
ICOG guideline says very clearly that if the estimated fetal weight in your third trimester scan is 4 kg or greater, then you should consider an abdominal delivery. Similarly, if you find in an Indian lady, if the estimated fetal weight is more than 3.5, 3.6 kilos, you may be better to err on the side of caution, especially if the Bishop score is also 4 or lower, then don't induce. A primary cesarean section may be the safer way out. At the same time, if your bishop is more than 4, cervix is inducible, she's a multiparous woman, you don't have a difficult, you don't anticipate a difficult delivery, and otherwise, if she is well controlled, you may attempt vaginal birth, with of course keeping in mind that she's a very high risk for having shoulder dystocia. Having said all that, remember shoulder dystocia is something which usually does not happen when you expect it. It happens when you least expect it. It happens when you and I, as senior people, are never around. The people who have to tackle shoulder dystocia
Yeah.
are the nurses and the juniors. So here, by and large, though we talk about shoulder dystocia risk, here we are anticipating this in this group of women. And therefore, we take all the precautions, and typically, even if it does happen, you'll be able to tide over it. True shoulder dystocia, when it happens, usually doesn't happen in a diabetic. It happens in a low risk primary gravida where the bisacromial diameter and the shoulder deposition of fat is huge. That is what leads to the.
Thank you, sir. That was a nice answer. Another one is our set of populations at Madurai and around whole Tamil Nadu state. Other risk factors like hypertension, preeclampsia will be there. Most of the time, as per guidance, they are not going up to 39 plus 6 like that, sir. Many
If
of
you
the
have multiple factors, if you have poor control, if you find that there are other fetal complications, all the guidelines say that you can plan an earlier delivery. There is no guideline which says that in the presence of multiplicity of factors and high risk complications anticipated, you take her till 39 weeks. None of the guidelines says that. You can get away with an earlier delivery, but it has to be with good NICU backup, with good coordination with your neonatologist, and a good counseling session to ensure that the couple and her caregivers have understood the risks associated.
That's good, sir. Another one, fetuses with the VSD, ASD, can we retrogradely going towards that parents and see the pedigree, like pedigree we are seeing, no, whether they were diabetic or like that. Can we think in that way, sir? Because one of the anomalies are
Cardiac anomalies are known to be more associated. Neural tube defects are also known to be more affected in women who are diabetic. But of course, all of these will be picked up if you do your first and second trimester anomaly scans, if you do your fetal 2D echo, which we in metro cities are doing universally for almost everybody now.
yes, sir. Yes, sir. Thank you, sir.
Pratik, can I add something to what you've said?
Yes, sir, of course.
Yeah. Okay. Dr. Mahalakshmi, one thing which is very, very important and it is recommended is fetal 2D echocardiography. So this is something which
Yes,
should
sir.
be done.
Yes, sir.
All
Yes, sir.
women who
But
have
sir,
gestational diabetes or hyperglycemia pregnancy in general, number one. Secondly, the recent study by Dr. Sheshaya has talked about fetal programming. Now, what they are recommending is that we should try and do the diagnosis of HIP as early as around 8 weeks. And if
8
we
weeks.
aggressively control sugars at that time, that will have a positive impact on the fetal programming. So the chances of the baby turning macrosomic or diabetic at a later date are far reduced once we do this intervention. So, these are small things which we have to keep in mind and then implement it, because they are doable things.
Yes, sir. Yes, sir. That was a nice answer, sir. Thank you. Thank you.
Yes, sir. Thank you so much, ma'am. So so coming to the end of the session, shall we conclude, sir?
Yes, sure.
Yes.
So I think I'll propose a vote of thanks on behalf of ICOG first, and then you can.
Yes, sir. Yes. Yes.
Right. So thank you, dear friends and colleagues, for joining this program today. Wonderful interacting with you all. Thank you, Pratik. Thank you, Lata, for being excellent speakers that you are, and keep on contributing to ICOG academics and perspective. We are missing Charmila, but she's one of the key conveners of this activities. And Madhu, special appreciation for your contribution, because you are the one who are ensuring that people join in time, their CVs are there, and of course conducting the whole program. Thank you very much.
Thank you so much, sir. So coming to the end of this really wonderful session. So first and foremost, I would like to thank Parag Biniwale, sir, our chairperson-elect of ICOG, for giving us this really informative session with wonderful speakers. And I would like to thank our convener, Dr. Charmila Ayavu, ma'am, Vice President of Foxy. I thank our office bearers, our President, Dr. Jaydeep Tang, our chairperson of ICOG, Dr. Parul Kondawala, sir, Madhuri Patel, ma'am, Secretary General of Foxy, Sheila Mane, ma'am, Vice Chairperson of ICOG, and Sarita Balaru, ma'am, Secretary of ICOG, for all the support rendered. I thank our esteemed speakers, Dr. Parag sir, Dr. Pratik Tambe, and Lata Chaturvedula ma'am, for this really informative and practical talk, and with key take-home points. And I would like to thank all our presidents and secretaries of the societies of Madurai, Dr. Mahalakshmi ma'am and Dr. Padma ma'am, Tirunelveli Society, Dr. Sujata ma'am and Dr. Gayatri ma'am, Thuthukudi Society, Dr. Pungoday and Dr. Pungoday ma'am and Dr. Jasmine ma'am, Nagarkoil Society, Dr. Sundarnarayanan sir and Dr. Rashmi Ajit ma'am, Teni Society, Dr. Shanta Vibala ma'am and Dr. Nivedita ma'am, and Pondicherry Society, Dr. Lata and Dr. Veena ma'am, and Tiruvannamalai Society, Dr. Radha Madhavi and Dr. Alamelu ma'am. So thank you so much for coming together for this program. And last but not the least, I would like to thank all our delegates for joining. And I thank the ICOG technical team, Nilima and Gauri, for all the support rendered. Thank you very much. Yes.
Yeah. Thank you very much.
Thank you for including me.
We'll meet again soon.
Yes.
Thank you.
Thank
Bye,
you.
everybody.
Thank you.